Good evening, and welcome to the fourth educational webinar, Allergy Expert in Action, Alexa. This webinar is supported by Nutricia Specialized Nutrition. The webinar will take the format of two individual presentations. These will be delivered by our guest speakers, and each presentation will be followed by a dedicated question and answer session. You have a chat tab that you can use, but please submit your questions using the question tabs only that you can see on the right of your screen during the presentation. You can send your questions while the speaker is presenting. The speaker will then reply to as many questions as the time will allow. To start this webinar, we would like to welcome Dr. Sandalova. So we were supposed to start with Dr. Migdadi, but he is having issues connecting. So give us just 1 minute and then we will put the slides of Dr. Sandalova. Here we are. Dr. Sandalova is a senior scientist and she's a personalized nutrition D-Lab in Danang, Singapore. She's also a visiting scientist in Utrecht University for pharmaceutical science, and Utrecht University is in Holland. So we are very happy to welcome Dr. Sandalova to join us this evening. Dr. Sandalova, if you could come on stage, please.
Hello, good evening. Thank you for your introduction. And thanks everyone for joining today to discuss opportunities and challenges in allergy prevention. I was really hoping to have the nice introduction by Dr. Migdadi, but I will be the one to start. And hopefully he will be able to solve the technical issues later. So today we will talk about hydrolyzed protein. So why hydrolyzing a protein? And are all hydrolysates the same? So we all have heard that allergies are on the rise worldwide. This is true for most countries in Europe, Asia, Americas, and some examples from Singapore. So the Growing Up Towards Healthy Outcomes in Singapore, for short, GUSTO study, reported at 5 years of age, 35% of children had positive skin prick test or were sensitized by an allergen. 26% had eczema. 22% had wheezed or used a nebulizer, and almost 40% had rhinitis. Another interesting study in Singapore reported that 80% of adolescents were sensitized to house dust mite. The study was performed in young students, and the students who migrated to Singapore allowed to assess how long does it take to get sensitized in Singapore. And they shown that after 8 years of living in Singapore, there's a high risk of being sensitized to house dust mite. A study in Iran showed almost 11% of pediatric asthma. A systematic review from Arabian Peninsula showed big ranges of asthma, eczema, and rhinoconjunctivitis. While overall, we can say that prevalence and burden of allergic disease is high worldwide. Why is that so? Let's look at the evolution of care. How did we move from avoidance of allergens to active tolerance development? So in the past, it was recommended to avoid allergenic foods by mothers during pregnancy and breastfeeding and by young children. It was thought that infants' immature immune system cannot respond properly to an allergen and more likely to develop allergy. However, it was not taken into account that the immune system needs to see an allergen in order to be able to tolerate it. The immune system needs to be educated. Moreover, strict avoidance is very hard to achieve. I remember that some of my friends, they were complaining because they didn't know what to eat during pregnancy and breastfeeding, because their doctors recommended them against having their habitual foods. And the choice of foods become extremely limited. Let's look at the journey through time in allergy prevention evolution and how did the guidelines changed and the recommendations evolved. So in 2000, The American Academy of Pediatrics recommended maternal restriction of cow's milk, egg, fish, peanuts, tree nuts during lactation. Also, solid foods should not be introduced into the diet of high-risk infants until 6 months of age, with dairy products delayed until 1 year, eggs until 2 years, and peanuts, nuts, fish until 3 years of age. Is that possible? Is that possible to ensure that there is full avoidance of so many different foods? In 2006, avoidance of allergenic foods was still recommended. However, there was more emphasis on ensuring the nutritional sufficiency. Indeed, if you avoid so many foods, you need to make sure that your food is still nutritional enough. 10 years later, in 2016, early active introduction in attempts to reduce tolerance started to take stage. Yeah. There were active attempts to induce tolerance, and there are multiple studies that appeared. 2 years ago, in 2018, early active introduction made it into some of the guidelines. There was wider acceptance of baked egg and milk, despite still having significant challenges. So what was thought in the past in terms of immune system? It was thought no exposure, no response, no allergy. However, is it possible to fully avoid the exposure? There could happen that is unintended exposure, not through the normal oral route, but through the skin, for example, especially inflamed skin in eczema children. Indeed, a study in Australia showed that children with eczema were sensitized to egg even without have ever eaten egg. So maybe the full avoidance, total avoidance, is not possible. So what do we evolve to now? Now we understand that it is important to expose child to protein, to train the immune system to recognize the protein as safe in a proper gut environment through the oral route and in a proper gut environment that is ready to receive that protein exposure. So let's look at the Australian guidelines. The guidelines in Australia were one of the first to introduce points about the early solid food introduction. So some of the key points were start to introduce solid foods around 6 months of age, not before 4 months of age, when your baby is ready. If possible, continue to breastfeed your baby while you are introducing solid foods. Include common allergy-causing foods until 12 months of age. These foods include egg, peanut, cow's milk, tree nuts, soy, sesame, wheat, fish, and other seafood. Studies have shown that it may reduce the risk of allergy. This is a very important point. So once the food is introduced, continue to give these foods to the baby regularly. Because if you give once and then drop it, and then after a year or so give again, actually there's a risk of developing allergies. So it's important to continuously give these foods to the baby. And the last point, raising concern, that is important to note that some babies may still develop food allergy despite following this advice. So this is the first attempt to explain how is it possible to introduce foods to attempt to prevent allergy. However, there are a few issues with this. First of all, safety. That was the last point in the guidelines. So how can a parent be sure that when she's introducing new food, the baby is already not sensitized? We have discussed just now earlier that children with eczema can be sensitized to egg without ever eating egg. And how the parents can be sure? Is it possible to test every child before he's getting the new food introduced? And the second issue is one-sided approach. Not only exposure, the exposure is not enough. We need to have the gut environment right. If there is a dysbiosis, if there is some signs of inflammation in the gut, it's not the right time to introduce. We need to optimize the gut environment. So let me introduce you the dual approach. First one is the controlled protein exposure. And the second one is optimizing the gut environment, preparing it for the exposure. The rationale for this dual approach comes from nature, from human milk. Indeed, human milk has both concepts. So a very controlled protein exposure in orchestra of ways and gut microbiota modulation through probiotics and delivery of beneficial bacteria. Human milk is quite unique, and there's multiple components of human milk that attempt to educate the immune system of the baby. For example, human milk contains intact proteins and protein fragments from maternal diet within hours after intake. It also contains immunoglobulins, and the allergens can be free or complexed with immunoglobulins. That's also another way to control the protein exposure. There is also multiple immune modulating factors in milk, such as infantile bacteria and prebiotics, or the food for beneficial bacteria. This is one of the major components of human milk. So let me share with you some of the functions of human milk oligosaccharides. First of all, and the most important, is the prebiotic function. It stimulates the growth of beneficial bacteria and activity of beneficial bacteria, and both are equally important. It has been shown that even if you have a beneficial bacteria, but it's silent, it might not be as helpful. There was a study where the bifidobacterium were grown on glucose, and the same bifidobacteria was grown in human milk oligosaccharides. And the study has shown that only the bifidobacteria that was grown on human milk oligosaccharides had an anti-inflammatory effect on human intestinal cells. So both growth of beneficial bacteria and activity modulation is important function of human milk oligosaccharides. It also has a direct effect on immune cells, which has been shown in studies in vitro, actually when it stimulates the tolerogenic environment. And also it was shown to block the route of infection for multiple bacteria and viruses. In an attempt to mimic the human milk oligosaccharides, a specific prebiotic mixture was designed to mimic the size, the linkage, building blocks, prebiotic function of human milk oligosaccharides, the short-chain galacto-oligosaccharides and the long-chain fructo-oligosaccharides. What I would like to highlight here, that this is hundreds of molecules. Yeah. So for example, a non-fucosyl lactose 2-FL as one molecule of human milk oligosaccharides. It's a trisaccharide. The phosphorus is actually a mixture, just like human milk oligosaccharides, an orchestra of molecules that is ensuring the diversity of microbiota to support child's development. So here we discussed some options how to prepare the gut environment to optimize it to receive the controlled exposure by the protein. So now let's talk about controlled exposure. And what do we actually mean by tolerogenic capacity of hydrolyzed protein? Before we do that, it's fundamental to understand how the immune system develops and how could it lead to a healthy or tolerance induction to food or to allergic reaction. The interaction of two cells that you see here precedes the development of the T cell. So this amoeba-shaped cell, called an dendritic cell, it actually processes the protein and cuts it into smaller pieces. So it's natural for immune system to process the protein into smaller pieces. What you see here in the green bean here, that's actually the peptide that was processed by the dendritic cell and presented on its surface to be recognized by a naive T cell. So by this interaction with the dendritic cell and a specific peptide that is presenting, the T cell will decide its fate to go into a healthy pathway, a T-regulatory cell development, or into a topic allergic pathway, the Th2 cell development. The Th2 cell facilitates the development of IgE and a future allergic reaction, whereas the T-regulatory cell, well, as the name says it, it would regulate the immune system and do not allow it to respond to an allergen adversely. Moreover, this T-regulatory cell produces some factors which creates a microenvironment that is tolerogenic. So when we hydrolyze the protein, we cut the protein into smaller pieces. And some of these pieces may facilitate more the Th2 development in allergy, so-called an allergenic epitope, what you see here in pink. And some of them would support more the tolerogenic environment, the T-regulatory cell development, what you see here in blue. So when we want to hydrolyze the intact protein, we want to make sure that this specific reaction, which cuts in specific places, actually will reduce the amount of allergens and increase the amount of tolerogenic epitopes, thus increasing the tolerogenic capacity and reducing the risk of sensitization. So this hydrolysed firstly was checked for safety. In vitro assessments confirmed that this hydrolysed has less than 1% of immunoreactive protein. And also preclinical studies has confirmed that there was no signs of sensitization and no allergic skin response and no anaphylactic reactions observed. So then let's go step by step. How do we develop this concept and this hydrolysed? Firstly, screening of sequences with immune potential, so those peptides, those pieces of proteins, specific sequences that has a higher tolerogenic potential were identified. Then this tolerogenic efficacy was validated in vivo models. And then it was confirmed that multiple batches of hydrolysed contain those tolerogenic sequences. Firstly, the animal model. Peptides were identified and tested in an animal model. What you see here on this slide is that the animals were sensitized with whey. So the control animals, so the first bar, the second and the third bar are allergic animals that were treated either with saline or with a mixture of specific peptides. What you can appreciate here, that the animals that were treated with specific peptides actually had a reduced, significantly reduced skin response to an allergen. So indeed, the peptides were able to treat those mice from responding to whey, an allergic whey. Next, these peptides were confirmed to be present in multiple batches of hydrolysates. So using the LC-MS, it was confirmed that these peptides are present. Exactly those sequences that were identified to work in a mouse model were present also in the hydrolysates. And third, not last, it was tested on human cells in vitro. So it was shown that these peptides are recognized by dendritic cells, by human dendritic cells in multiple donors, both adults and children, as well as these peptides induce activation of T cells and proliferation of T cells also in multiple donors. So as you can appreciate here, this is the screening of multiple peptides. So the milk proteins themselves in the beginning, and then different peptides derived from these proteins. So as you can appreciate, the peptides 1 to 3 were the ones that were activating the T cells the most. So that's actually the peptide sequences that we want to enrich our hydrolysate with. So to summarize, coming back to the immune development slide. So what we know now is that these peptides that are present in our hydrolysate, they're actually presented by human dendritic cells. And these peptides are able to activate human T cells. I would like to summarize here. No countries are immune immune to rise in allergic diseases. Nutrition can be an effective way in preventing allergy in early life, and we need to start in early life. Not all hydrolyzed formulas are the same. We aim to increase the tolerogenic potential that will steer towards the healthy development. And I would like to thank you for your attention. And I see that there are a lot of questions, which is nice to see. Helen, would you like to help me with some of the questions?
Okay, so let's go. I'm going to take the first one. Do you think that hydrolysis of protein may carry a risk of carcinogenicity on the long run?
Well, I think it will be lower risk the other way around. It has never been observed that there is any carcinogenic effect of specific peptides. Actually, the peptides has been attempted to use not only in allergy, but also in other fields. For example, autoimmune diseases, they identify certain peptides that they use also orally, also with gut support, to treat autoimmune diseases. Many peptides are used as drugs as well. But the peptides that we are talking here as food peptides, this is the food that we eat. And as much as we don't observe the cancerogenic effect of food, we also will not observe the cancerogenic effect of that food when it's hydrolyzed. So I hope I give you some confidence there.
Okay, so we'll take the second one. To continue food twice weekly, even if a baby developed allergy?
Totally not. Totally not. Also in the guidelines, if you read, you can actually search for Australian guidelines and download them. They are freely available for everyone. It says that if you observe any reaction to the food, immediately stop it and seek advice from the doctor. So absolutely not continuously introducing. You need to seek advice from the specialist and follow the advice of the specialist. And that's exactly the issue that I have been talking about, because when we start introducing, especially in high-risk babies, the parents are very often afraid. And there were multiple studies that showed that the parents are afraid. And that's why working on a controlled exposure that could give more confidence to the parents, ensuring them that this will not cause allergy, as one of the ways to support the healthy development and reduce allergies. But absolutely not. If allergy, go and see doctor, stop it.
Do you recommend hypoallergenic formula?
Well, let's talk about definitions here. So hypoallergenic formula is the one that doesn't cause allergy, right? So what we are talking here about is hydrolysates. And I think actually probably Dr. McDaddy will talk about it later as well. So what we talk about here is hydrolysates, and they are hypoallergenic because they don't cause allergy, right? So recommending hypoallergenic formulas to everyone, no, that's not the position. We need to look at the babies that are at risk, the parents that are afraid to introduce the foods, and also consult your doctor, obviously, if you have concerns with regards to hypoallergenic formulas.
Let's take another one that's highly rated. Do you recommend to start hydrolyzed formula in infants who have family history of allergy?
That's a very good question, and you have to check with your country recommendations, because in many countries, like for example in Singapore and some other countries, their guidelines do recommend to introduce hypoallergenic formulas or hydrolyzed formulas to babies who have family history of allergy. Some of the guidelines do not recommend, and it depends on the evidence present in the country and overall evidence. So please do check with your doctor and check with your local guidelines on the recommendations.
Okay, we're going to take one last question. Do you recommend partially or extensively hydrolyzed milk in eczema babies?
That's a good question, and probably maybe Dr. McDaddy will also address it later. So the difference between the partial and the extensive hydrolysate is that partial hydrolysate, as what I was talking about, is just hydrolyzed formulas. Extensive hydrolysate is when they even further filtered to reduce any risk of reaction. So the extensive hydrolysis are recommended for treatment when there is a confirmed allergy, and the partial hydrolysis is recommended for prevention. So again, if you have concerns with regards to the eczema babies, and if they don't have any food allergy, any obvious allergies, then probably partial hydrolysis would work. However, if you want to be cautious, then extensive, start with extensive and then slowly introduce partial and hopefully full cow's milk protein. Thank you.
Thank you, Dr. Sandalova, for this insightful session. We will now go back to Dr. Miqdady's presentation, the role of nutrition. Thank you. So we will go back to Dr. Miqdady's presentation, the role of nutritional intervention for allergy prevention and allergy prevention guidelines. Dr. Miqdady works as the Division Chief, Pediatric GI, Hepatology and Nutrition Division at Sheikh Khalifa Medical City in UAE. We are very pleased to welcome Dr. Miqdady to join us for this event. Go ahead, Dr. Miqdady. Oh, we cannot hear you. Can you hear me? Dr. Miqdady? Okay, we're having technical difficulties. It's probably the internet nowadays. Everybody's on the internet at night, so a little bit of patience, please. We cannot hear you well. It is cutting a lot. Probably your internet connection that's a little bit low. Let's try to remove, I will remove the camera. Maybe it will take less internet and we will be able to hear you. Let's try it this way. Can you hear me?
I can hear you, yes.
Okay, now we can hear you.
All right, perfect. I don't think you have to see me. I was stressed for the last 30 minutes or so trying to make the connection. So if you
No
can
problem.
hear me, if you can hear me now, I think we will go ahead and start.
Yes, we can hear you fine.
Perfect. So my role today, I will be talking about the role of nutritional intervention for allergy prevention and the allergy prevention guidelines that we developed in collaboration with some of you guys in the audience, I guess, about the Middle East guidelines based on what's published in the Middle East and what's available internationally. Perfect. I will be asking you questions throughout the presentation to make sure that this stays interactive as much as possible. All right, so we'll start by the background, then we'll move into the Middle East guidelines, and at the end, I will present to you what I think is beyond the guidelines, what's coming in the future, and how can we use it for our patients to their benefits. I think we all in this webinar agree that cow's milk protein allergy is a common problem, but often it's not properly diagnosed. I'd like to see in your chat and your comments if you believe it's an over or if it is an underdiagnosed problem. I believe in some instances it's over and in some instances it's underdiagnosed. Why is that? Because there is no specific test that can be used to confirm diagnosis. You know, for other diagnoses, like you do a blood or an imaging or an X-ray or ultrasound or a culture and you get a diagnosis. In this one, you don't have that. I see Dr. Hala, Dr. Shaman, Dr. Sayed, things underdiagnosed. Okay. And with this over or underdiagnosis, it might result in unrecognition of the symptoms, and the patient suffering might continue if we underdiagnose, and if we are over diagnosing, it can result in problems by restricting the diet of the patient or changing him to an expensive formula unnecessarily. So hopefully we can shed some light on how can we help in the appropriate diagnosis without over or under diagnosis of this issue. I see somebody said الصوت منخفض. I hope it's better now. Okay, Perfect. The strongest predictor of the allergy is the genetics, i.e., if there is a family history of allergy, it increases your risk of allergy. Uh, but looking at the top of this graph, if none of the parents have allergies, both of them are healthy, they never have allergies, it does not mean that their child will not have allergy. No, 5 to 15% of them will continue to have allergies. So a negative family history does not exclude allergies. Still around 10% might develop allergies. If one of the parents have allergies, then the risk will be increased up to like to 30% that the child or the infant might have allergies. If another sibling has allergy, again, it's a 30% risk. But if both parents or one parent and one sibling, the risk will increase to around 50%. So it's like half of the infants will develop allergies. If both parents are affected by the same allergy, then probably the risk will be even 60 and 80%. So if both of them have the same allergy, you are almost sure that the infant will develop allergy. So
Dr. McDaddy, I'm sorry
let's.
to interrupt. Just don't put the microphone so close to your mouth because otherwise we hear like a breath, you know?
Oh, I'm sorry.
Like this, it's good. Perfect. Thank you
Is
so
it
much.
good?
Sorry for
All right,
interrupting.
all right,
Yes,
good.
thank you. Sorry.
So, what's the take-home message? I think if you are still lucky and if you are still single and you are planning to marry someone, ask the future spouse, is he or she or anybody in their family have allergies? And you have to ask him or her specifically if they have eczema or they have asthma or allergic rhinitis or food allergies. Because whenever I ask my patients, do you have any family history of allergy? The answer is always no, as if it's a shame. You have to go specifically ask them about skin allergy, respiratory allergy, and allergic rhinitis, as well as if they have any food allergy. This is the graph, and I'm sure you have seen it many times before. This is talking about the allergic march. In the x-axis is the age in years, and in the y-axis is the prevalence among prevalence of several allergic disorders in these children. As you can see very clearly, early on life, when you are young, your skin and GI allergies are the commonest, manifested by eczema and GI manifestations. Once you become a teenager, your eczema and your GI symptoms will wane off and disappear, while the respiratory allergies become more obvious, namely the rhinitis as well as the asthma. So it's probably the same disease with different manifestations at different age groups. Well, this allergic march teaches me that hopefully if we can intervene early on life when the infant still young infant, hopefully we can stop this allergic march, i.e. if we can intervene in the first year of life, hopefully we can prevent the future manifestation of allergic rhinitis or asthma in these patients. And I think that should be the goal for us as pediatricians, is to try to prevent the allergy development. As we all know, there is no cure for allergies, but if we can intervene early in life, hopefully we can save this young patient the suffering in the future. All right, talking about the hydrolyzed formulas, I think it's very important to develop the basic understanding of the formulas. The hydrolyzed formulas, we have three kinds of hydrolyzed formulas, if you will. In the left side of the slide, you can see the partially hydrolyzed, which means that the protein is chopped off into a small peptide. In the middle is the extensively hydrolyzed. These are the formulas when they are more and more hydrolyzed, so they become short peptides and maybe a little bit of free amino acids. To the right of the slide, you can see the free amino acids. This is when the formula becomes single amino acids, i.e. there's zero risk of allergy to the protein. This diagram, I have shown it to most of our colleagues earlier in a presentation. I think it's still very important. Let's walk you through this slowly. At the left side, you can see the intact protein, which is the protein available in the breast milk as well as by the standard formula. When you hydrolyze it a little bit, it becomes the partially hydrolyzed. The name of the partially hydrolyzed is formula X followed by the suffix HA. So XHA, YHA. So all the HA formulas are partially hydrolyzed. And as you all know, this is used for prevention of allergy, i.e. somebody who does not have any symptoms of allergy, but the dad or the mom has or had allergies, or the older sibling had allergies. This is when you give them the HA formula. Moving to the next one, which is the extensively hydrolyzed and the amino acid formulas. These are the treatment that can be used for somebody who already have allergies. So the extensively hydrolyzed and the amino acids are for patients with allergy, while the HA is for prevention of allergy. As you can see, moving from the left to the right side of the curve, the allergenicity will decrease, the tolerance will decrease, and the taste will be bad, i.e. the standard formula tastes the best. Partially hydrolyzed, the taste will be affected a little bit, and the extensively hydrolyzed and the amino acids, they are less and less tasty because the virtue of their nature of the protein. Please note that the extensively hydrolyzed and amino acids, they are lactose-free formulas by nature, while the HA formula still contains lactose, and lactose is important as a prebiotic, as you all know. So extensively hydrolyzed amino acids, they have to be lactose-free formulas. All right, let's move on to the Middle East guidelines. As probably you have seen a copy of these guidelines, they were developed in 2016. I was fortunate to be one of the co-authors of this important publication. When we looked at the studies available that time, we noted that in the Middle East there is limited publication about that, and the literature is really not that rich in the Middle East, at least at that time, and there was no obvious regional guidelines. The absence of a clear guidelines, we felt that we might miss the opportunity for change, which is I showed you, remember earlier, in the first year of life. We want to recognize these patients early before they develop allergies, and treat them early on life before they have any problems. And if you miss that opportunity, unfortunately, this particular patient might be at risk of asthma and allergic rhinitis later on life. So what I will present to you today, hopefully, is a simple algorithm for prevention and another simple one for treatment. I hope that you'll find them user friendly and easy to follow. We removed a lot of the details just to keep the message short and sweet to you all. If you are interested to have the full publication, it's available online at the Pediatric Gastroenterology, Pathology and Nutrition Journal, and you look in for my name and you probably will find it easy there. All right, so for the prevention algorithm, the first question you ask the mother: can you breastfeed the child? And if the answer is yes, then your job is very easy. If the mother is planning to breastfeed the child, so the best thing you do is exclusive breast feeding for the first 4 to 6 months of life. This is what you need to do, and that's probably the best way. And there's a lot of evidence supporting that exclusive breast feeding will have the best chance to decrease the development of allergies. If the mother is not planning to breastfeed the child for whatever reason, the next step will be, if there is a positive family history of allergy, to use an HA formula, a partially hydrolyzed formula for the first 4 to 6 months. The same way, like exclusive breastfeeding 4 to 6 months, and HA for 4 to 6 months. But keep in mind that even if the family history is negative, there is still a risk of developing allergy. So it might not be a bad idea to give HA formula to anybody, whether they have a risk or they might not have a risk there. All right, and this was also supported by the European Allergy College, as well as by the NIH and the NASPGHAN and the American Academy of Pediatrics. They all agreed that breastfeeding is probably the best way to prevent cow's milk protein allergy and other allergies, and contact dermatitis, and maybe others as well. In the same publication, we stressed the point that there is no evidence to restrict the maternal diet, whether she's pregnant or lactating. And again, this is for prevention. So the mother should have a balanced, healthy diet during pregnancy, as well as during lactation, without any restriction, obviously, unless the mother, she's allergic to certain kinds of food. Solid food should be introduced between the age of 4 months and 6 months. But after the infant completes the age of 4 months, you have 2 months period to introduce all kind of food, even allergenic foods. If you do it before the age of 4 months, you will increase the risk of allergies. If you wait till after the age of 6 months, you might increase the risk of allergy. So between 4 to 6 months is the ideal time to introduce all kinds of solid to this infant. If breastfeeding is not possible or not available, then the use of partially hydrolyzed, i.e. HA formulas, will be indicated in these infants. All right, so let me make sure everybody's awake. Let's get one of the poll questions, and I'd like to see everybody participating. Let me ask you the first question. During COVID-19 pandemic and the lockdown procedures that probably we all are under now, whether you live in UAE or in the GCC or outside, are you eating more? If you say yes, please go to the poll question and submit yes. If you think you are eating less, submit your vote as no. Helen, 68% are honest people and they say yes. 35, they are eating less. You know what? I want to meet the people who said they are not eating more, because definitely I think most of us are eating more during the lockdown. Let's go to the question number 2. Well, some of us may be looking like this during this lockdown period. All right. So how many meals you are eating per day? Click A if you think you are eating 1 meal per day. Click B if you think you are eating 2 meals per day. And click C if you are eating 3 meals per day. And if you are honest, click the open buffet, like you are eating almost 24/7. Well, now it's Ramadan, so it's a little bit less. But between iftar and sahur, are you eating like open buffet? All right, I see. Most people, I think, they kick 3 meals a day, even during Ramadan. So that's iftar and suhoor, and in the middle of that, some of people are open buffet, like 16%. Okay, so I'm pleased I'm not the only one who's eating more during this lockdown. So I think what's happening with us during this lockdown is what's called the stress eating, or the emotional eating. And during the stress eating or the emotional eating, you are eating food in response to your feeling, which is mostly being bored during periods of time, not because you are hungry, just sitting at home doing nothing. So to relieve your feeling of boredom, you start eating more and more. And I'm sure our colleagues in the dietitians, they will have epidemic of seeing overweight and obesity, and they will be busy after this lockdown is over, as well as our bariatric surgeons. All right. I got this snapshot from the BBC, and the BBC have suggested some suggestions. I think they borrowed some of this from the WHO, talking about how can you avoid the stress or the emotional eating, by drinking more water, having some herbal tea, trying to do some exercise at home, cooked meal rather than ordered food from outside, obviously avoiding uh, snacks and avoid unhealthy snacks and fast food, and to always stock on healthy food, not to fill your kitchen with unhealthy food. Well, obviously it's easier said than done, especially in Ramadan. We eat a lot of sweets, unfortunately, and it's full of calories. All right, so back to the main business. Let me ask you another question. I'd love to hear everybody's answer to this. And I think this question is a very practical question. So now you are attending in the nursery. You have a 32 years old lady who was tested COVID positive. She had a beautiful, healthy baby girl who's born. The mother asks you about the breastfeeding. Click A if you believe breastfeeding is indicated, as the baby will get IgA through the breast milk. Click B if you believe breastfeeding is indicated, as the baby already has IgG through the placenta. Click C if the breastfeeding is not possible because of the risk of transmission. Click D if you believe expressed breast milk is an option. Let me see. All right, let's go to them one by one. The first thing, breast milk, as it has IgA, well, there's no evidence to that yet. We are not sure if COVID-19 will induce IgA antibodies yet. Typically, no, because it's a respiratory virus. Usually the GI viruses induce IgA, but again, everything is possible. So A is probably not correct. Breastfeeding is indicated as the baby already has IgG. We are not sure. It has to be probably a past infection to develop IgG and pass it. As you all know, we still have a problem in the IgG testing available in the market to diagnose COVID. A lot of the IgG antibodies, they found it in the serum of people. They are IgG, but they are non-neutralizing antibodies, i.e. they are not helpful in prevention of the infection, at least for now. So B is not correct, probably. C, breastfeeding is not possible because of the risk of transmission. I think that's wrong too, because yes, direct contact will give the risk of infection, whether you are breastfeeding or not breastfeeding, and contact precautions has to be observed. D is probably the most appropriate answer, I believe, because expressed breast milk was not shown to have any virus, as the recent publication by the American Academy of Pediatrics. So if the mother wishes to breastfeed, probably she can. You can express the breast milk and give it to the infant. That should have almost a zero risk of infection, and there will be no direct contact there. And if the mother wants to directly hold the baby, she has, of course, to use the appropriate PPEs. But this was an interesting question. If you want to learn more about breastfeeding and COVID, please refer to the AAP. They published their guidelines, I think, sometime in mid to late April of this year. All right, excellent. Let's move on to the management part. And again, I will keep it simple and sweet and short and direct to the point in our algorithm. I opened my mobile, and this is one of many pictures that I got from one of my patients. As you can see, this is a diaper full of stool, and there is some streaks of the blood. This is the commonest, by far, commonest manifestation of cow's milk protein allergy. So I would suggest to all my fellow pediatricians, don't open any WhatsApps before iftar time, because that might turn your appetite down. Well, most of us probably their appetite is open and large, so even if you see this picture, you still can have iftar. The other manifestations of cow's milk allergy is several, including the IgE or the immediate type, which is the anaphylaxis and the shock-like pictures and the FPIs. I'm sure you all have seen some of these patients. The GI manifestations are mostly the blood in the stool. Others can be also a manifestation of allergy, like reflux disease, vomiting, and abdominal pain, anorexia, and others. Skin manifestations, probably in almost half of the infants with cow's milk protein allergy, they have a skin manifestation by eczema. Sometimes it's an obvious eczema, sometimes it's less by having like a dry skin. Some of the infants, uh, they have respiratory symptoms by like allergic, sorry, by, yes, by allergic rhinitis, sometimes by cough, and sometimes by wheezes. And many of these patients were diagnosed with viral infections. But what's different about the viral infection, that these symptoms will continue for long periods of time. Some people say the sound is off. I think you have to check your setting and make sure it's on for the sound to be on. Somebody said he cannot vote, Fatima. I think you can. You should be able to vote if you go to the polls part. All right, this is our simple algorithm, and I will walk you step by step. Again, this is for somebody who's born and they have already symptoms of allergy. At the top of the graph, you ask the mother a simple question. Can you breastfeed? And if the answer is yes, then your job is done. I advised the mother, said the best thing is to exclusively breastfeed your infant for 4 to 6 months. That will be the best cure for allergies. But during this time, the mother has to avoid any dairy products, any milk, any yogurt, any cheese, any kind of milk products. If they are from Jordan, they should avoid جميد عشان المنسف, because المنسف is yogurt based. الأردنيات كلهم راح يزعلوا هلا. فavoid any dairy and breastfeed your infant. So that should take care of the most majority of women who are breastfeeding. If the mother does not want to breastfeed, then you ask her the simple question.
Dr.
Keep your amino acid formula for 1 year. Perfect. If it is not anaphylactic reaction and not breastfeeding, you have to go down in the chart and you put him at the bottom where you see in the yellow, which says extensively hydrolyzed formula, and you continue the extensively hydrolyzed formula for a year of life of the child. And you bring them back to the clinic in 4 weeks. If they have responded to the extensively hydrolyzed, then life is good and everything is perfect. If they have not responded to the extensively hydrolyzed formula, then you switch them to an amino acid formula. If somebody has allergy and you have started them on an amino acid formula, 100% of them, they should respond, i.e., 100% should have no allergies if you put them on an amino acid formula. If they don't respond to an amino acid formula, check compliance. If they are compliant, then and there's no response, then this infant does not have allergy, he has something else. If he has allergy, he should have responded to that. All right. Some people say the sound is not clear. I hope the sound is better now. I did not change any of the settings here. Again, whatever intervention you do for the treatment, you do it till the age of 1 year. At the end of the first year, most infants they should outgrow their allergies. Again, some of these infants might not outgrow their allergies, but 80-85% they should outgrow their allergies. All right, so I think, yeah. Again, if the mother is breastfeeding, you have to give her calcium supplements. Okay, I'll skip these because we talked about them. All right, I want to highlight a very important paragraph in this publication by the SPGAN. Actually, this was published in 2012. It has been a while. The SPGAN have said amino acid formula should be the first line of treatment in two conditions. One, if it's an anaphylactic reaction, i.e. IgE type reaction, or if it was a severe allergy. In this publication by the SPGAN, they said severe allergy if the protein or the albumin was low or the child has faltering of growth. I.e. if you see an infant today who have low albumin and his growth is affected, this qualifies for what's called a severe allergy, and this patient probably is better off to be started on an amino acid formula because probably he will have or he already have severe allergy. No time to waste it in giving him extensively hydrolyzed formula. Okay. So let me ask you another question. I would love to see your response to this question. I hope I made it very clear that partially hydrolyzed or the HA formulas should not be used to treat cow's milk protein allergy. So I expect everybody to say no to this question, that HA formula should not be used to treat allergy. So if you have allergy, please go to extensively hydrolyzed or to amino acid formula. Do not use HA. HA is for prevention only. So if allergy, extensively hydrolyzed. If it's severe, amino acid formula. I'm glad to see that more than 80% have said correctly, HA is not to treat, it's just to prevent. So if you have symptoms, go to extensively hydrolyzed or amino acid formula. All right. Before I conclude, let me present to you this publication, which I called it Beyond the Guidelines. This is not in any guidelines yet, but I'm sure it will be in the guidelines in the future, hopefully after this COVID. All right. The conclusion I will hopefully will lead you to believe in it is that based on two things. 100% of patients with cow's milk protein allergy will respond to an amino acid formula. So if you have allergy, you give your infant an amino acid formula, he should respond 100%. If he does not respond, this is not allergy. Look for some other etiology. Clear? So this was stated in several publications. I'm quoting Van den Plas in 2014. He made this very clearly. So amino acid formula is 100% cure for people with allergy. So this have led some authors like Morris in 2016 to suggest the following, let's call it diagram or a flow chart. Morris and his colleagues said, you have a child with symptoms, that's not clear. Crying, irritability, eczema, not gaining weight, but it's not typical of allergy. There's no obvious blood in the stool. Story is not totally clear. Morris and his colleagues have suggested the following. He said, listen, give this infant amino acid formula for 2 to 4 weeks. Bring him for follow-up in 2 to 4 weeks. If the symptoms have improved, this is allergy. Done. This is like a diagnostic test. If the symptoms did not improve, this is what, not allergy. Go and look for other causes of the symptoms. If this is allergy and he responded to the cow's milk protein allergy, if it was mild to moderate, go to an extensively hydrolyzed. If it is severe, keep him on the amino acid formula. And I found this approach fairly reasonable approach, because this will make the life easier for you and will give you more confidence in the diagnosis. In 2 weeks, you will decide yes allergy, no allergy. Very simple question. Improvement in symptoms, resolution of complaints. I'm happy. This is allergy. No obvious response. This is not allergy. Go and do whatever you need to. And after 2 weeks, you have the option to step down to an extensively hydrolyzed formula, and then or to continue in the amino acid formula if they are having mild to moderate symptoms. All right, so ladies and gentlemen, I'd like to leave you with a few take-home messages. The first thing is the family history and the genetics is the most common predictor of allergies. I saw one of our colleagues have a comment here saying, if you're gonna ask your spouse if she has allergies, then you will limit your options. More than 50% of the people have allergies. Well, I can't remember who was this colleague, but for us, the married people, maybe it's too late now. You cannot change your spouse. Well, I don't know. Maybe some people can change, but for many of us, it's too late. If you're still single, that's probably a good time to save your children from having allergies. The guidelines I presented to you, they are region specific, but I think they can be applied in many regions of the world. And hopefully we kept them user friendly and straight forward. For prevention, the best thing is breastfeeding or HA formula. Breastfeeding is not available. If they have symptoms, whether it's GI or respiratory or skin symptoms, the best thing is to exclusive breastfeeding and the mother to avoid any dairy products, dairy, milk, yogurt, cheese, and mansaf if they are from Jordan. And extensively hydrolyzed for the ones with the anaphylactic, for the anaphylactic ones, we give them an amino acid formula, or if they have low albumin or severe allergy, extensively hydrolyzed for the other ones. And I left you with one example how to use the amino acid formula as a diagnostic tool. You will have the result in 2 weeks if the symptoms disappear. I will be happy to take any questions or comments, and I will be happy if Helen can put me back on stage.
Okay. Thank you, Dr. McDaddy, for another educational and insightful sessions. We're just going to go on with the questions. I'm going to try to read a few of them for you. Let's find one that has a high rating. Is there any possibility that the mother nutrition early during the pregnancy sensitized the developing fetus and increased the chance of allergy?
Actually, this is an excellent question. There is evidence against that. That the mother, if she avoids food, the baby might be at higher risk of developing allergy. So we allow and we encourage the mothers to have unrestricted diet during pregnancy. And the science behind that is if the mother eats, for example, let's say oranges or apples or milk or whatever, this antigen will be processed in the mom GI tract and in her body, and small amounts of this antigen will be presented to the placenta, to the child, among with all the other protective things that passes through the placenta. So hopefully it will induce tolerance in the infant, and this tolerance will decrease the risk of allergy. So please advise the mom to eat normal, healthy diet, not to avoid anything, even allergenic food. So the mother should eat eggs, should eat fish, chocolate, nuts, drink milk and dairy products during pregnancy, and the same goes through the lactation. Any restriction is not necessary, might increase the risk of allergy and might put her at a risk of nutritional deficiencies.
Okay,
Next question.
Next question. For how long do you recommend using of HA formulas as a prophylactic to stop the allergic march?
Well, there is no comparative studies about the duration, but most of the experts they say at least 4 to 6 months, because after 4 to 6 months you start introducing solids to the diet. Other experts they say till the age of 1 year, because we suggest to continue the breast milk till the age of 1 year. So I would say until most of my mothers, if they are happy with the HA formula, they can continue till the age of 1 year. But if they stop after 6 months, I don't get very upset either.
If a baby has only eczema and no GI symptoms, nor respiratory, do you advise EHF, pH, or standard formula?
If the baby have eczema, I would think that could be one of the manifestations of allergy. And again, 50–60% of these infants, they have cow's milk protein allergy. If the eczema is mild, I would give them extensively hydrolyzed. And if the mother is breastfeeding, I would tell the mother to avoid any milk and dairy products. See them in 2 to 4 weeks. If the symptoms improve, here you go, you have your diagnosis. If the eczema is severe and the itching is a nightmare and the child cannot sleep well, I will give them an amino acid formula for 2 to 4 weeks. See them in 2 to 4 weeks. If this was cow's milk protein allergy, you will see an excellent response to that, and you have your diagnosis. If you give them an amino acid formula for 2 to 4 weeks and the eczema is not improved at all and they are compliant, then this is not allergy. This is some kind of other eczema etiology, not cow's milk protein allergy.
Okay. Dr. Sandalova, would you mind coming back on stage so that we can take 2 or 3 more questions all together? So let's leave her some time to come back on stage. And meanwhile, I will look for the very interesting questions that were left unanswered. Thank you very much.
I think,
yes.
Sure. There is a question with a rating of 4. It says, for how long amino acid formula can be used and what is the substitute for lactose? Well, if the patient has an indication to give an amino acid formula like severe allergy or failure to thrive or low albumin or anaphylactic reaction, I would give it till the age of 1 year. By the end of 1 year, most of the infants, they should outgrow their allergies. But again, 80–85% they will outgrow the allergy. This means 10 to 15 or more, they might continue to have allergies. You might continue. The substitute for lactose, usually they have a glucose, maltodextrin, which is a carbohydrate to substitute for the lack of lactose. If your question why they don't have lactose in the extensively hydrolyzed or the amino acid formula, because if there is any lactose, it might contaminate it with cow's milk protein. So to be sure that this is a pure formula without any proteins, they have to remove the lactose.
Great, thank you. So I have a question for both of you. What is the ideal molecular weight in Dalton of different hydrolyzed formula HA, extensive hydrolyzed, and amino acids?
If this question for me, I have to go back to the slides.
I think it was for Dr. Sandalova at the beginning, isn't it? Or I'm not sure. I'm not sure. You can both reply.
Dr. Migdady has a perfect slide for it.
Oh, really? Okay.
That's the slide. You know, I have given this talk probably several times, well, more than several times. I still get confused with the numbers because it's not practical. In your practice, you don't check these numbers, but this is the numbers for reference if you guys are interested to look at it.
Yeah, these numbers are for reference. Actually, they are not really regulated. So when you put a formula on the market, you don't have to show what Dalton size there is. So it's a guideline, but it's not strictly regulated. So I agree with Dr. Migdady that it's sometimes can be confusing and you could see different numbers. But generally, these are the numbers that are recommended.
Okay. Should we start newborns directly on hypoallergenic formula?
I would say no. A newborn should be started in breast feeding when and if possible. That's the best way to prevent allergies. Uh, if the mother cannot breastfeed, this is very unusual because 99.9% of the mother should be able and can do good breast feeding. If it's an absolute contraindication, which is very rare, then the use of partially hydrolyzed might decrease the risk of allergy. But again, breastfeeding doesn't have to be either 0 or 100%. I tell my moms, listen, I understand you have issues, whatever it's social, medical, work, or whatever. You cannot breastfeed, but at least try as much as possible. You know, if she can breastfeed 5 times a day and times formula, that's much better than 8 of them to be a formula feeding. If she cannot do five, if she can do three, this is better than two. If she can do at least once or twice a day, definitely it's a positive thing to do. And a lot of these factors in the breast milk, it doesn't have to be in a huge amount to cause the preventive effect. So any breastfeeding is better than zero breastfeeding. If absolutely no way, like the mom, whatever happened to her, she cannot breastfeed, then the use of an HA is probably indicated to decrease the risk of allergies.
I have one last question. I'm not sure if you answered it already. What is the proper Dalton size in extensively hydrolyzed formula for CMA?
For cow's milk allergy, we said it's less than 3,000.
Okay.
But again, these numbers are not written in stone. In that definition that the slides I put from the American Academy of Pediatrics, they said this is the guidelines, but it has to be shown in clinical studies. So you cannot use any formula that somebody tells you it's an extensively
Exactly.
or
Totally.
it's a formula. Yes, Elena.
Yes, I totally agree that we should not look at the sizes. We should look at the test clinical studies that actually demonstrate that this formula is efficient and it does not induce allergy. So don't be so obsessed with the Dalton size. Just look at the clinical reference.
Absolutely.
Okay, one last question. Do you recommend using AAF for infants with GERD after 2 months of giving AR formula with no improvement?
So the question about GERD. GERD can be one of the manifestations of allergy. That's correct. So if you have GERD and you think this child or this infant rather have enough symptoms or suspicion of allergy, then a trial of the AF formula can be used in these infants. And again, use it 2 to 4 weeks and you see the response to that formula. If there is a good response, could be allergy. If there's no response, then this was not allergy. If your question at what age can you start amino acid formula, you can start it at age of 0. There's no minimal age to start it. So if you have enough suspicion of allergy and the baby is not breastfed, then extensively hydrolyzed or amino acid formula can be used at any age, whether it's a diagnostic tool or as a therapeutic tool.
Great. Thank you both for your time and for those great presentations that you did. We really appreciate it.
Thank you.
Thank you.
Thank you very much, you all, and have a good evening. Thank you, Lena.
And a nice weekend.
Thank you.
Thank you, Dr. McDaddy. Bye-bye.
Bye. We would like to thank you all for taking the time as well to attend, and especially in those uncertain times. A recording of this webinar will be available shortly, and a link will be sent to your email. We would also appreciate your feedback on this session to help us develop and refine for future sessions. A link to the feedback form will be sent to you. And we will be hosting another webinar soon, the details of which will be communicated in the coming days. So we hope to see you all again soon. And until then, thank you very much for attending and take care.